So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard.
What's good, fam? It's your host, Jim Pruitt, aka PharmD, and I'm bringing you another episode of the Pharm So Hard podcast. We're fresh off of Empower, so we're feeling empowered, of course, and this is going to be another special episode. I have the biggest boss of them all with us today, the pharmacist. Like you know, you have to be real if you're the pharmacist. So again, guys, I'm Jim Pruitt. I'm just super happy to have this episode going on. We're going to talk about some interesting things, but today's title is going to be Pushing P. That's right, baby. Pushing P, Phenobarbital for alcohol withdrawal. And I have the biggest boss of them all with us today. Go ahead and introduce yourself for the audience.
Hey, Jimmy. Hey, everyone. My name is Marc McDowell. Thank you so much for having me today. It's kind of a dream and looking forward to this moment for over a year now. But first, I got to credit where credit's due. Jimmy, what a phenomenal conference we just came out of last week. Up in Chicago, I think almost every ER pharmacist I know attended. And we've been talking about it for the past week or so. So well done. Looking forward to next year's.
Appreciate it. It's going to definitely be cool. So let's just get into this. This is something that we're all super interested in. I think everyone has an opinion about alcohol withdrawal. I think
truly
that's one thing. Everyone has their own opinion. My ED docs, they have their opinion. And even if you talk about like different, like when did you grow up when it came to this? If you're newer, you're like, oh, I want to get into phenobarb. And then if you're practicing for like 20, 30 years, like I've used that in the past and it's whatever. But before we get deep into like the drug part, this is something I like to start everything off. Be like, why is this even important? Because like everyone's like, what are we talking about here? Why is this important to you?
Yeah, and I think it's by virtue of where I trained and kind of the initial residency research projects I was involved with. So I did both of my years of residency down in the south side of Chicago at the large tertiary trauma center, Advocate Christ Medical Center, and in my second year specialized in EM. But I was really fortunate to kind of train under and do research with one of the big alcohol withdrawal gurus, Purvi Shah, down there. So she has been a thought leader in this area and has been researching it, for close to a decade. And really kind of got in tune with this idea of severe alcohol withdrawal, not just being how the patient presents, but it's really almost like a hospital long course, right? And the way that I always phrased it is the mantra I always try to use is early recognition means a lot, right? Because, we all know the statistics, like 85% of Americans are going to have at least one drink of alcohol in their life, but, X percent is going to come into the hospital for alcohol withdrawal, right? And I think those patients declare themselves pretty straightforward. I think a lot of ourselves and our learners and our physician colleagues recognize those patients right off the bat. I think what some of us struggle with sometimes is those patients who get admitted for CAP or maybe for a long bone fracture, wind up on the floor for a handful of days and then just decompensate abruptly, right? Either, we hadn't done a great history and found out, there was some underlying alcohol use disorder, or the patient just had never gone into alcohol withdrawal before, right? And those patients, I think, are substantially harder to manage, for a number of reasons. So I think if we look at it through that kind of lens or that paradigm of, these patients presenting at different states in their disease state, phenobarbital actually, I think, can make a lot of difference in almost every type of presentation we look at.
Absolutely. And I think that's just the big thing is like, if you see a patient, these are not just ED patients, and you're fortunate, you get to see kind of the ED component, see the ICU component, and just being, I think even in residency, you see them everywhere. So I think, again, as you mentioned, the big thing is like being able to capture these people early and at least identify them early. So that's going to be something what I think is important. And the cool thing is being a pharmacist is almost completely drug driven. Except for the few people who wants to give a beer consult. Like I had that in PGY too. The pharmacist had to take care of the beer consults for people. And it's like, dude, I don't want to go to the pharmacy and grab a Colt 45 for this guy. Okay. Like I'm not bringing that to the ED. but again, I promise you people would ask for, hey, can you just give this guy some beer? And it's like, it's just not the same, or just like ethanol. Like, dude, come on, guys, come on. So let's not go that route. But
I would love to know the 340B pricing on that.
that would be great. But can you just give a quick breakdown of PATH though? Again, I try to mention it, but you probably can explain it much better than I can.
I'm an ER guy, so I like to be brass tacks, very straightforward. And I think this is a disease state a lot of our learners are going to be familiar with and probably have heard a lot about recently. So I'll not spend too much time perseverating. But essentially, your exposure to chronic alcohol or chronic, GABAergic drugs is going to lead to a downregulation in your GABA receptors over time. I think which we're all familiar with. We'll also see a concomitant upregulation of your NMDA receptors, potentially of your AMPA receptors as well. And that's just, again, due to a prolonged exposure of those GABAergic drugs, specifically alcohol in this situation, or ethanol. And so when that's abruptly taken away or kind of tapered off, we will start to see some autonomic dysregulation and some CNS autonomic dysregulation in the setting of the lack of presence of ethanol or those GABAergic agents. So what's interesting is that phenobarbital might actually work on all three of those receptors that I just mentioned. And that's really interesting because we look at the other medications that we have, and they're more isolated, more targeted at these different receptors, which, theoretically makes more sense. But, we do have now some substantial data that shows that, this phenobarbital in conjunction with or as monotherapy really does have a role in the treatment of severe alcohol withdrawal.
Absolutely. I think it's just one of the things that is actually just super cool. If you just start looking at all the different components of how phenobarbital works, and you're like, wait a second, like this is really cool. At high enough levels, we act as GABA, or, we can get that AMPA receptor. It's just pretty cool. You can hit everything instead of me having to give benzo and then give ketamine and then find a way to give a large enough dose of something to actually act as GABA. And it's just super. And when I found that out, I was like, whoa, this is super nerdy. This was actually my first ever pharmacy pearl, like 4 years ago. It was like phenobarbital for alcohol withdrawal back like 2018. So it was like one of the coolest things for me in the world.
Yeah, very high yield, right? And it's so interesting about the history of phenobarbital. That was a precursor well before we had chlorodiazepine epoxide in the 60s, right? Yeah. This has been around for over 120 years now, but it's just only kind of resurged over the past 10, 12 years, which kind of coincided with the start of my career. So I kind of feel you talked about different timelines. Like I grew up with phenobarbital. I almost feel like a sense of, and it's kind of cool to see it's one of the more popular talks that people are giving these days.
Yeah, and especially as more and more data comes out. At one period of time, it was more controversial, and I got a message, and the guy was like, it's interesting. It's like it's not very controversial anymore, and it's like I was like, well, okay, well, I guess not, but still, people are, depending on what camp you're in. If you're at these big academic centers and you're doing a bunch of this stuff, and it's like you talk about it a ton of time, that's cool, but I have to remember, and Empower actually helped me quite a bit with this. People practice style in their locations and what they're used to is so different. It varies so much. So I think us continue to talk about these things and being able to kind of dive into how to make it happen is a pretty unique thing. So it's not controversial, but I would say getting it done consistently throughout the US probably still is. So
very true. And I think if you print off the chat section from any part of that conference, you'll see a variety of opinions. Absolutely.
Absolutely. So let's try to transition now. As we talked about kind of the path, though, this is I think probably one of the more interesting components is the scoring tools that we use. And realistically, what's happening at the bedside. And I think we're fortunate to be, practicing at the bedside. We can see what's actually happening. But can we talk about the CWA score or any variation that you've seen of the CWA score utilized?
Sure. Yeah. And I think you hit the nail on the head. This is kind of a fun part to talk about too, and this is one of my favorite topics to go over with learners, right? They all learn the CWA AR in school, they're used to, it's a 10-point system or a 10 criteria system. And the first thing I always do with my learners is I ask them, hey, think about the last, wedding you went to, or think about the last, maybe your bar crawl for your graduation. Give yourself a CWA score for that next morning. Think back about when, you're waking up, give yourself a CWA score. And, these learners it's remarkable every single time. Their minds are blown how high they score just from going to a party, right? And I think that's a very elucidating and almost like light bulb moment for some of these patients, or some of these students, I should say, that, this is a good tool and this can recognize a lot of things, but not necessarily in tune with, severe alcohol withdrawal requiring, acute intervention, right? And obviously it's a very messy tool, and it's very, very subjective. And so much so that especially like, let's take, for example, the prime patient, you could use a CYAR score. And someone who's in the ED who's conversant with you, or someone who's in the general medical floor who's conversant with you, the interrelator reliability for these scores is just, it's phenomenally low, right? And that's if your patient is coherent enough to answer these questions, if the patient's coherent enough to want to be conversant with who's ever interviewing them as well. So my second tool I always do is I tell my students, or even my residents, hey, there's nothing stopping us, as the pharmacist, from going bedside and calculating a CWA score on our own, right? So it's a routine thing I have all of my learners do. And what the best is, if I have two learners on at the same time, a P2I2 and a P4 or a P3, send them in at the same time, have the P4 or the senior one lead the questioning, but both independently score, right? And they come back and I say, don't discuss it, just give me your answer. And you will see drastically different scores. And it's not because they did anything wrong, but it's because it's such a subjective tool, right? And that's in the setting of our most ideal patients, right? And as I think we all know, and is very often quoted, that the CWA score and the CWA AR specifically was never ever validated in any type of ICU or step down patient, right? And that just makes a lot more sense. That number, of 20% of patients not being able to verbally converse with you and answer those questions appropriately is just going to go up exponentially, especially when we start talking about mental status changes or respiratory decline, or eventually intubation as well. So, there's some recommendations out there by different guidelines. The American Society of Addiction Medicine, it's a phenomenal society. They are very, very on top of their game, and very, very publishing heavy as of late, right? It's a growing specialty. And they make a clear statement saying in the ICU, there's really no place for CWA scores. We should be essentially using a RAS score at that point. And I think that's reflected in the practice I've grown up with, and my training and what I've seen. I think that's probably pretty ubiquitous with other places too, which makes a lot of sense. I have seen a little resurgence in the literature talking about the MIND score. That's just a slightly different take on the CWA score, with a little bit less opportunity for variability on the patient's end, right? A little bit less subjective data supplied by the patient, and more objective data, such as hemodynamics, like that too. But the last thing I really want to always touch on here, and what I really want to hone in with my learners, is if you look at all those 10 points or 10 criteria on the CWA AR, there's one that you definitely cannot fake. The litmus test, I'll say, and that's diaphoresis, right? So, it's always brought up in talks, and I think that it's got a place here as well. So if it's really, really hard to fake diaphoresis, guys, so make that maybe the first step when you're assessing a CWA score for yourself.
Absolutely. And I think sometimes we're fortunate to have like an experience of seeing these patients over and over again. And we just usually walk in the room, it's like, oh yeah, that's what it looks like. That's legit. And it's so hard because like they can go and score the patient and you're like, yeah, no, he needs a little bit more. And it's like, you can try your best to make sure we use all these scores and these tools, but realistically, I love it when my senior medical resident and the attending walks in, we look at the patient, talk to the nurse, get everyone's concern, and we're like, okay, this is what the textbooks say we should do. This is what we're going to do based off experience of managing these patients before. And this guy, and it's always the look like shit score. Let's add that one in there as well. Because some of these guys look just horrible, man. And we have to get them taken care of now, or they're going to seize on us. And it's going to be a nightmare when we send them to the unit.
Like you had said earlier, you catch them all early. And you make a great point, Jimmy. It's the gestalt, right? We see all this data set about physician gestalt, versus like these PE rule outs, these MI rule outs. And the gestalt always does just as good, if not better, in certain clinical scenarios. So I think I like to think that there's some pharmacist gestalt in there too. And like you mentioned, always get the most veteran ER nurse, and they can just say, that's a real litmus test.
Yeah, that's the real. If you get all the senior people from every specialty to come in and walk into it together, I don't care what type of CT you got or what type of well score, whatever you got, it's going to be correct based off what we've seen. So lots of patho, lots of just scoring, and then I think everyone can have their own score. So when I was at Grady, we had a GAWA. We had a Grady one, and then I believe we were speaking with Lance out there in Denver. They had their score as well. So everyone's gonna have their own score, and like none of it's wrong. Like I think we're gonna point that out there. It's just how can you find a way to most consistently score people and identify them as being at high risk of having more severe symptoms. So I think that's something we should just point out there. But let's transition to the drugs, because this is going to be the key part. The lovely benzodiazepines. Can you just give a very brief overview of the benzos, and then we're going to spend the bulk of our time talking about phenobarb.
Yeah, and I think the analogy that gets often used here is if you got a hammer, everything's going to look like a nail, right? And if that's the only tool you got and it's the only tool you're used to, you're going to use it, right? And is it going to work a lot of the times? Absolutely. Is it going to work every time? Absolutely not, right? So kind of knowing what's like in your armamentarium is really, really important. So obviously it's a direct agonist of GABA A. It's going to work in conjunction with your actual free-floating plasma GABA, right? And the analogy I like to use is you have a door, right? And that's your GABA receptor. Giving a benzodiazepine is like turning that doorknob and opening the door, right? It's going to allow those chloride ions to flow through, and then it's going to close again. I think that's a pretty good example. The data that talks about, GABA is, stems from like, as early as like the 1950s, and chlordiazepine epoxide, as I mentioned, being the first benzodiazepine that was approved in the US. And what you can see here is, versus placebo, obviously GABAergic agents such as benzodiazepines are going to do much better in terms of seizures, in terms of delirium tremens, and even in terms of death. We start talking about the different types of benzodiazepine strategies. I think by the time, Jimmy, you and I come to practice, symptom triggered benzos, or STB, was really, really the mainstay. And not to say that STB has better outcomes in terms of, DTs or respiratory events compared to scheduled benzos, but I think it exposes you to a lower amount of total benzos with those same results, right? And I think, again, just in our short careers, benzos have gotten an extraordinarily bad rap in certain scenarios. Obviously not with the alcohol withdrawals especially, but we do know there's like some long-term sequelae with giving too much benzo in this case as well. And I think that the other mantra I want to recognize here is there's a lot of ways to skin this cat, right? You said there's a lot of different ways to look at assessing severity. There's a lot of different ways to approach treatment too. And, if you got something that works for you, I wouldn't necessarily say that's wrong, but maybe there's something a little bit more data that we have now that can maybe kind of reshift that paradigm.
Absolutely. I think benzos, again, it's just something I always consider benzos for alcohol withdrawal, the vancomycin of alcohol withdrawal. We just do it because we think it, but again, it may not work for every patient. It may necessarily not fit. It's the key for that lock. It may not be the right one. And it starts getting interesting. And when I started to note, I saw a few cases of the benzo-induced like delirium, the benzo-induced like acutely, because I've always was told, benzos are bad just for intubated patients that are on it for a prolonged period of time versus the big doses that we have to give for alcohol withdrawal. And I was like, wait, this guy's getting like worse. Like this guy's not getting better. And that's when I start hearing about the paradoxical reactions that you can have with benzodiazepines at these bigger doses. And it started to make me think like, hey, there has to be something else we can use, and we can go back and forth, guys. And I'll put some stuff in the show notes, whether it's diazepam, whether it's lorazepam. Many people are not necessarily using midazolam, just the PK doesn't add up as much. But we can talk back and forth all the different benzos that we have. Again, and I want to caveat that this is mostly talking about the more severe patient. So we're talking about IV symptom trigger. Again, it doesn't matter what you use. You're going to be using much higher doses. But at the same time, I think we have to just continue to look at, okay, what is this patient? What's going on? And whether we're actually having the end result that we're looking for. Because it only takes your nurse coming back to you 3 or 4 times saying, hey, this is not working. Give a bigger dose or do something else until you're like, okay, my hands are tied. I have to switch something up. And that's where phenobarb for me comes in. When I started to notice people reacting very differently, and I was like, wait, phenobarb is like legit. And I would use it a lot more. And I was like, this is amazing. So can you give us just a brief overview of phenobarb and like, why is it such a, phenomenal drug when it comes to alcohol withdrawal?
Sure. Starting with, the receptor mechanism again, it's going to work on the GABA A receptor, but just a slightly different subunit, and it's going to affect it slightly differently. So going back to that door analogy I'd use, benzos are going to open that door and close it again. I always tell my learners that giving phenobarbital is like opening that door and then kicking a doorstop in it, right? So you need that GABA in conjunction with that benzodiazepine to open up that door. The phenobarb is just going to prolong the opening of that door as well. It's throwing a doorstop in there, allowing more chloride ions to flow past that membrane. And what's really cool is it has these pleiotropic effects too, like we mentioned. It's going to antagonize NMDA receptors, going to antagonize AMPA receptors. Again, most of that data is coming out of murine data with rodents, gerbils, and rats from the past couple decades. But it does seem to have a really, really profound effect. And I think you mentioned it, like your first time using phenobarbital in a severe patient, you're like, no, man, this guy looks like he's going to buy himself a tube. Give it to him. Half an hour later, it's a pretty profound effect. And I don't think anyone's going to forget their first time using it for severe alcohol withdrawal, where you thought, man, this guy just bought himself, ICU admit, 10 hours later, he's chilling on the floor. So it's just a phenomenal drug. And the often touted, prolonged PK that, certain, maybe physicians or colleagues get a little worried about. I look at that as a benefit. It's got this auto tapering that you see. People often bring up, hey, it's hepatically metabolized. And that's true. It does go through phase 1 and phase 2 hepatic metabolism. And in your bad cirrhotics, that's again maybe even another benefit, right? That's going to hang out even longer. We know it. If we can get into the data, but we know that's going to hopefully decrease your benzo exposure as well. You're going to get more bang for your buck, right? There's a lot of ways to slice and dice the literature, which we're going to get into in a second. But I mean, anecdotally speaking, it was a game changer, right? And I remember my first job out of residency. It was at a trauma center, but it was a little bit smaller, community-based trauma center on the west side of Chicago. And it was probably the first time that we'd ever done phenobarb. It was like maybe my first month there, and I came to the doc and I was like, "Hey, let's give this a shot. Otherwise, this guy's going to buy himself some rocuronium." And it was just seeing like senior nurses and some of the senior attendings being like, "Holy cow, yeah, wow, this is didn't think this would be possible. We were just kind of humoring you, but it looked. I think it was a game changer for them as well." So I encourage learners to kind of just keep that in the back of their minds.
Yeah, it's really cool. I remember one of the cases I had when I was in Augusta. I had a senior doc, and the cool thing about when I was in Augusta, most of their docs are military, so they have some type of experience prior to coming back to residency. And they've seen a lot of this stuff. They're a little older as far as an age, but they're a little bit more experienced. And I had a guy, and he was like, "Yeah, Jimmy, I don't know about this, man. This doesn't." I said, "Listen," I said, "give me 2 doses in 45 minutes." He's like, "What?" I said, "Just give me 2 doses." I said, "Realistically, I said, give me 260 and then 130 of phenobarb." He's like, "I just don't." I said, "Get all your stuff set up like you're going to intubate, do exactly what you want. Just the time it's going to take you to get everything else done. Give me that time frame and give me 2 doses." And he's like, "All right." I said, "Come here, look at the patient." He's like 4-point restraints, diaphoretic, just like, hallucinations, auditory, visual, all of it. He's scoring off the charts. My nurse is exhausted, exhausted from I think we gave close to like 40 of Ativan at that point. And we're just like, "I'm tired of this. Let's just intubate the patient just for the sanity of the ED."
Mm-hmm.
Gave him 260, he calmed down enough to where the nurse was like calling other nurses to come in.
Mm-hmm.
Patient. And we got him to a decent point. He still scored mild. I gave him 130, and I had the doc come in after that. And he was like, "What the hell did you give him?" And I was like, "Dude, this is phenobarb. I told you I think this guy can be a good candidate for it." He was like calling the other residents from other pods to come over. And it was like, "You remember this guy earlier today?" And I was like, "Yeah." And I was like, "What'd you give him?" He's just like sitting there just chilling, like sleeping. Like he was tacky to 150s, hypertensive to 180s. This guy's like all over the place. We give him 2 doses of phenobarb, and this guy's chilling in the 90s, heart rate wise, blood pressure's come down to normal, and he's like sitting there snoring, a good snoring, like, not that he can't protect his airway, but good. And this guy ended up going, we had to call ICU, had to actually come down, see the patient. They're like, "Yeah, we're not going to accept him." And everyone was just like blown away by that. And of course, it makes you feel great as a pharmacist that you can do that. And I always tell people that is one of my things. Where I say, I take you from ICU to ICU later. You can basically go somewhere else, like the floor or even home. And those are just big moments. And I think really key for us as pharmacists, if we can just know what it looks like, and we're just fortunate we can see it. But for me, I'm fortunate to work in states where I recommend it, I give it, I monitor the patient, and all these things are happening. And then you can show your team, like, I'm just as invested in this as you are. And it really just helps the overall ED. I would just say the throughput for other patients, because you're not constantly in the room. So for me, that was one of the big things. And it's really just unique, just using it. But the next part I really want to get into is just the data. And lots of times when we recommend certain stuff, people are like, that doesn't have any data. That's crap. And it's like, well, 2022, as of now, I feel very confident with what we have. And of course, we don't have all day to talk about it. But can you just like walk me through the things, the studies or the things that you care about? And let's just like walk through a few of those, because I think that people really need to know that there's at least something out there.
Absolutely. Yeah. And like you mentioned, there's too much to talk about, like just for this scope, and even for a conference, there's too much to talk about as well. But I'll try to hit on the ones that I think they're most important and the ones that will kind of shape my paradigm for how I approach different types of patients. So I think we can't get started without talking about Rosenson. I give so much credit to Rosenson and his colleagues for really, really bringing this back to the map. And I don't think we'd be in the same place we are right now without that study, right? And the best part is, it was probably one of the highest quality ones done that we have so far. Prospective, 100 patients, which is pretty remarkable for a prospective alcohol withdrawal trial. And, they went big. They went with 10 mg per kilo right off the bat, right? So this was early 2010s, like around 2011, it came out in EPUB. 2012, it was finally published in print. And essentially what they looked at was a 10 mg per kg load of phenobarbital up front, or your regular symptom-triggered benzos, right? And I think that's exactly what our docs want to see, right? That's the exact equivalency that we're looking for. What it really did show was, one, the thing that they're going to care about the most is respiratory depression, right? And really, there was really no difference between these two groups in terms of respiratory depression, in terms of who bought themselves an intubation. And the other really big win was where was the dispo for these guys, right? And just like you said, was it ICU later? I love that.
ICU later, man.
Yeah, these guys were going to the floor, man. These guys were going to their step downs. They weren't buying a unit bed. And you brought up a really good point with the anecdote you had mentioned from Bethesda, I think you said, was, in terms of resources, right? So patient outcomes, obviously very, very important. But think about that ICU bed as being a resource for the department as well, right? You're going to have, a septic intubated patient boarding in the ED. So this person, goes through their withdrawal state without being exposed to phenobarbital. It doesn't make sense, right? In addition to that, the nurses, going back and forth from your ADS to the bedside with 4 or 6 of Ativan every 15 minutes. It just doesn't make sense. And this study, I could talk about its benefits all day long, but it did come over some heats for a couple different things where a lot of the patients in the symptom-triggered benzo arm and the patients in the phenobarbital arm did actually cross over. Some of those symptom-triggered benzos got a little bit of phenobarbital, and then the phenobarbital arm got some symptom-triggered benzos. And really, I think that's almost a strength of the study, because that's my practice essentially, right? Load them up, put them on a CWA-AR score, whatever you use at your local institution, and it was safe. They kept these guys out of the unit still with that as well. And then the patients who got phenobarb loaded later, they didn't do quite as well, right? They still used a lot more resources than they needed. So I think that was just a kind of a validation to me. They still use the CWA score like I typically do. So, I mean, I know it's not as, validated in these severe patients, but it still got the job done. So I give a lot of credit to that research group. And I think, they've probably impacted a lot of lives, a lot of departments.
I think if you anyone who talks about phenobarb in the ED or ICU area within the last 15 years, you really have to bring that study up, because it really changed. Because the biggest thing that I have a hard time with is convincing my doc to use a big dose. And now when they mention that, it's like, oh, well, I know a study where they gave 10 mg per kg up front in the ED, and they're like, let me see it. And they read it, and it's like, oh, okay.
Yeah. And the really good thing that, my mentor, Porvi Shah, always brought up was, what's your status dose for phenobarbital, right? You're comfortable giving that to someone who's already altered, or someone who's going to be post-ictal, and you're going to think their airway is going to be okay, giving double that dose. So, but yeah, exactly right. Yeah, it's probably one of the most printed out articles I think I've printed in my career in the department. Yeah.
It's a constant reader for all residents that come on rotation with me. So again, if you guys are listening and you match the MUSC or you're at Grady, just know I'm going to ask you that. So get yourself ready for that. So what else you got for us? Because that's a big one. That's like the OG of phenobarb for us at this point.
Yeah, and I think moving on to the next kind of population would be the Nysavic and colleague trial. This is a little bit bigger, right? We had about 560 patients in this one. Unfortunately, it's retrospective, but what's cool about this one, or what's unique about this one, is it specifically looks like the general medicine population, right? They didn't look at severe patients in the ED. They didn't look at patients who had already bought themselves, an ICU stay. What they looked at was, phenobarbital monotherapy versus, symptom-triggered benzo monotherapy again. So very, very similar to what we saw in the past. But the really interesting thing about how they dose their phenobarbital is they used an algorithm in this case that one stratified them off of severity of alcohol withdrawal, or their alcohol withdrawal severity risk, looking at things that I look at every single day, right? Have they gotten phenobarb in the past? Have they been intubated in the past for alcohol withdrawal? Have they ceased from alcohol withdrawal in the past? All these, big red flag items that make you think, hey, this is a serious player. They work that into their dosing up front, and then they stratified them by their respiratory risk as well. So, do they have concomitant sedatives on board? What have they already received? And based off, those two factors, they provided a mg per kg dosing to their clinicians up front in the meantime. So, just by virtue of that, and this being a retrospective, chart review that looked at, protocol change, we got to see some pretty cool information that, again, phenobarbital did just as well in these general medical patients who were loaded very, very highly up front compared to symptom-triggered benzos. And if you imagine, let's say you're a doc in 2015, Rosenson paper's been out for about 3 or 4 years. It's kind of getting some news out there in the foam world, maybe a podcast or two. If you have a serious player, you're going to want to put them in that phenobarbital arm. And that was exactly what they did. They saw that, they could choose either one of these. Patients who were more severe or had a more severe history of alcohol withdrawal wound up in that phenobarbital arm statistically significantly higher and more often. And they still did just as well as that symptom-triggered benzos. So there was almost a bias against phenobarbital cohort, and they still did just as good, right? And then the last caveat I always bring up with this trial is so cool. The patients who technically failed the symptom-triggered benzo arm, they also were kind of administered some phenobarbital, and they kind of did a subgroup analysis showing that, yeah, if they had probably received phenobarbital up front, they would have had a much, much better time. And that really reinforces what the Rosenson crossover showed us as well. Yeah. So I think just another lens to look at this for in terms of our general medical patients, not just our severe, ICU patients.
Yeah, so I think that's one of the key things I'm looking at across the board, and what makes me feel very comfortable now is that really you can go down. 2019 was big. I think there was like 4 or 5 studies that was published, but the cool thing is that you can look at it in any way you want it to. You can look at it as you just give a load up front and then immediately follow it with the benzos. You can do all phenobarb compared to benzos. So, and then the cool part is each population. There's some ICU studies, there's some floor ones like this one here, and there's some ED ones. So it makes me feel very comfortable now to know that we can play it however you want to. And I can slice and dice this however you want. If you want to give a big load up front, we can do that. If you're nervous, I can literally give you multiple doses, 260, 130, my weight up to where I want to, check a level for you to make you feel better. And then we can go from there. But we're just at a really cool point with phenobarb from a data standpoint that we have a little bit of something in every population. So that's the cool part. Any other one did you want to highlight? Because it's so much out there now.
Truly, I think, there's a couple other ones that are interesting that talk about, using smaller, scheduled tapers. And I think that's really showed some benefit in the Tidwell and colleagues study. But the last one I kind of really want to highlight is more recent. And you had mentioned 2018 being a big year, the Nelson study. That was a really good, another retrospective one that looked at kind of those 3 different cohorts that we kind of talk about, pure phenobarbital monotherapy, phenobarb plus symptom-triggered benzos, or just symptom-triggered benzos on their own. And again, this is retrospective, a little bit smaller, and it really showed that the main outcome in most of these studies is ICU admits, and that there was no difference between any of those, right? And you got to think about in terms of resource utilization, your nurse's workflow, just total drug exposure. It just makes a lot more sense to maybe gravitate away from symptom-triggered benzos as being your hallmark for general medicine patients, severe ED patients, and severe ICU patients.
Yeah. And an interesting part is that you sometimes these studies, and I think now that I'm getting into resident research and getting more involved, these studies can't capture all the things that the authors wanted. So like you're doing these studies and you're like, man, can I find the amount of time that my nurse was in the room? Can I find that? Like, can I find if I gave phenobarb, a couple of doses up front and I got that taken care of as a push or a piggyback, and I got that the patient was fine. They didn't have any more difference compared to me going every 15 minutes, like every 15 minutes. And then the fact that across the board, one thing that I really enjoyed was the fact that people did not get tubed more. People did not have like lower GCSs more. So I think it's just something that we had to look across the board and say, man, if I can design a perfect study and I can capture these things from the chart, I would love to know, again, an ED resource standpoint, or just as a unit resource standpoint, because in this world that we're currently in right now, we're talking March 2022, we don't have a overabundance of nursing staff. We don't have an overabundance of people, physically at the hospital, or who's comfortable doing these things. So it's something we should definitely look at a little bit more, but of course that's challenging to actually study.
That's a phenomenal take, right? Yeah, that's one of the most limited resources we have right now is our nursing colleagues. That's well said, very well said.
So I think one of the things that comes up quite often, and I think people are now comfortable with the data, and what they want to know is like, how do I do it? Like, how do I do it? What's the best way to do it? I'm just gonna spoiler alert from my standpoint. I don't know what's the best way. I don't know what's the best protocol. Like, what's your take on like operationalizing all of this to help people? Because again, I've seen it a ton of ways.
That's a great question. And I kind of reflected on this a little bit when we're preparing for this and trying to think of like an algorithm that I have in my head and kind of combining all the literature we had talked about, feeling comfortable with higher dosing, seeing Tidwell's risk stratification. And I guess the first question I asked myself in my decision tree is, have they been intubated in the past for this? Have they gone through DTs in the past, or have they tolerated phenobarbital in the past? And what's their serum ethanol level right now? And if I get any one of those giant red flags, where this person, comes in usually at a 150 and now they're at a 60, and their CWAs are a little acting up, or they, had required phenobarbital the last 3 times they're here, I'm going to give them 10 milligrams per kilogram up front. Mm-hmm. And I'm going to tack on some symptom triggered benzos in addition to that. And to be honest, this is what I've been doing for years, and I've had pretty good success with it too. And we see a pretty severe patient population in Chicago, especially on the south side, and we're very, very fortunate to benefit from this. One of the kind of newer additions I've kind of implemented after kind of re-going over this data again is, I feel comfortable giving a smaller loading dose of 5 mg per kilo to some of these patients who are kind of perseverating, kind of hanging out, whether are they going to buy themselves an ICU time, or, can we trust them on the floor? Are they going to be too much of a headache? I'll give them 5 mg per kilo. And again, throw in that symptom triggered benzo order set on there as well. And, the nice thing is you can always give more, right? There's nothing stopping you from giving another 5, another 130 or another 260 in half an hour, or even half a day, right? And then I do see sometimes, some of our younger physician colleagues get a little excited. They see phenobarbital work really well in the past, and then they'll get a guy who gets, 2 Ativan, and then an hour later they come back and he's cursing at him while he's in the hallway, right? And they're like, oh, this guy definitely needs phenobarbital. Mm-hmm. I'm not so sure. I think this guy, we got to figure out what his disposition is going to be for the long term. Is he going to be admitted in the first place? Is he going to be able to walk home, or is he going to come in for, again, I think the example I use is like a long bone fracture, or he needs like a THA or something like that, right? And I think those are kind of the more nuanced questions you have to follow when you get in. So I always ask my PGY2s this question then, Jimmy, is there anyone you wouldn't give phenobarbital to?
I think for me, I try to, those milder ones that we're not even sure. We're not even sure it's like it's going to score. We walk in and they score a 0.5 of lorazepam. I'm like, I can give them 130 and just, do it that way. Mm-hmm. But I think we're still benzo symptom triggered. Now, there are some shops that we can switch over to phenobarb symptom triggered as well. And those are the ones where you can get 65 of PO phenobarb. Those are people I'm okay with, but it's not something. I think about the overall flow and my staff. I think right now, based off the current culture, those milder people, I keep away from phenobarb, because I think it just stresses the nursing staff out a little bit more. And I usually get more calls from that. And I think from a standpoint, if they're going to go home and drink immediately when we get out of here,
yep, I'm
just not as concerned. I have a real frank conversation with the patient. Hey, dude, what are you going to do when you get out of here? I'm trying to figure out a game plan for you. Oh, you don't have to give me nothing. Don't worry. And especially when I'm in downtown Atlanta, my patients are very straightforward with me. They say, okay, you may see me tomorrow for being here 2 drugs. So you don't have to worry about it. So I think it's the milder people who I'm just, I guess it could just be my ignorance, but I'm just not as concerned. And if they don't have a history, they're not diaphoretic, they're not scoring much, I'm okay with just using benzos. And if they want something, if they're interested in tapering and things of that nature, that's a different conversation. But I think in acute setting, I'm just not too concerned. And usually I'm busy dealing with other things. And the easy thing for me to do in that scenario, for not just me, but for my nursing staff and my physician staff to order, is going to be just the symptom trigger benzos.
Yeah, and there's something to be said for familiarity too, right? I mean, why make something more complicated that doesn't need to be? And I think you hit the nail on the head. Your biggest bang for your buck is going to be your more severe. The patients should potentially become more severe too. If I could add one more key point, and this is something I've seen that people almost get burned down once in a while, is I think we love phenobarbital, but I feel like we always sometimes overlook some of the drug-drug interactions with it as well. So obviously it's a potent 3A4 inhibitor. 3A4 inducer. So sometimes we see a lot of concomitant disease states such as CAD, or someone who's recently got stents. I always double check, make sure they're not in ticagrelor or not in azole antifungal before I pull the trigger on that. I've just seen people come kind of close to it, and I think that could be a deleterious, one, for the patient, and 2, for phenobarbital's kind of reputation in general if something were to go sideways.
Absolutely. And that's one thing I'm always keeping in the back of my head. Like, let's not mess this up. And
Mhm.
I just like to use it in the term that most of my nursing staff is like, that's why we don't have nice things. It's constant that way. And I think we have to remember, and I think ED pharmacists in general and people who work in the ED, you have to be kind of pull yourself back sometimes because we do so much and sometimes we can do so many other non-pharmacy things and we have so much non-pharmacy influence in our thoughts that we have to kind of pull ourselves back and think about the basics all over again because it can be a day where I'm running codes as the lead, I'm doing this different stuff, and I have to like pull myself back and like from a pharmacy standpoint, is this patient taken care of first? Drug interactions, drug disease state interaction, all those things are going to be key for me, and I have to like pull myself back and talk to my learners about it as well. So it is something to really be thoughtful of. Um, that's really the big part for me. I'm looking at our timing, and I know our audience probably is just like, come on, Jimmy, you just love this crap too much. So, so Mark, again, give me like a quick summary. If you like wrap it up a top of the discussion, how would you close this out for your learners?
Yeah, I would say that alcohol withdrawal is complicated and it's very dangerous, and you're going to see it ubiquitously for the rest of your inpatient career. That's not going to change. So again, the two mantras that Dr. Pruitt and I kind of reinforced a couple of times is early recognition, right? And the way you're going to be able to do that is by practicing your CIWA scores on patients in at the bedside, right? Going to them, talking to them, really understanding and seeing multiple cases and understanding what trajectory they're going to go on, right? And then two, understanding like kind of the armamentarium you have in terms of treatment of this, right? It doesn't necessarily have to be all benzos, doesn't necessarily have to be all phenobarbital. It could be a mixture of that, but just understanding that there's pharmacokinetic and dynamic considerations for both of those agents as well. And this is always a great time to kind of review the literature and dive deeper into it and really try to understand the snapshot in time, which was these studies were being done. What was the other available literature that kind of influenced their decisions about how they were making their algorithms and designing their trials as well?
Absolutely. That's great, man. And I think just realistically, again, for everyone who's listening, just think that there's so many ways to do this. And if someone says there's one way, I caution those people because the same things like when COVID first happened and we have COVID experts and it's like there's only one way to do it. I caution people who are just so absolute in their thinking when it
Mhm.
comes to this. There's many ways to use all of these drugs. Same thing like with ketamine, my favorite drug. There's many ways to use these drugs, and it's many situations where you have to really plan out what's the end result. And for me, dispo is going to be a big thing. So the first question I ask my doc is, are you going to intubate this guy or is this guy going to go to the unit? And that kind of helps me figure out where I need my dosing, and how deep to look into this and figure things out. So that's my major summary of all of this. Any final thoughts either from this episode or just in general? You got so much going on, and you work in I call it the triangle of the Midwest of clinical pharmacy.
Yeah, no, I feel very lucky to be, kind of be working in this generation of pharmacists, right, man? Especially the ER pharmacy. We're also plugged in, on Twitter, offline. I was so happy to meet you in person a couple months ago. That was great. So yeah, I think if learners are listening to this, I think EM's a phenomenal specialty because relatively it's pretty new, considering all their specialties. So a lot of opportunity to publish, a lot of opportunity to research, a lot of opportunity to make a big difference in our community's outcomes.
Yeah. And it's just for me, I would have probably had to do something else because this is like the perfect fit for me. It's just EM has just been one thing, and people say, why do you do all the stuff you do? And it's like, it's crazy when you wake up every morning, you're like, oh, I get to do the thing that I feel I was made to do. And for me, that's ED pharmacy, man. So I'm just super happy to be able to meet you in person. Even more excited to do this podcast together. And just want to close us out. And a few things again, Empower was, last week, and it was one of the biggest moments for me, being able to lead that and be able to have my team just really come through and pull me through the finish line because so many deadlines, so many things to do, so much going on. It was amazing to have 700 people from 10 countries just come to try to come together. And just the conversation, the chat is still crazy to me, like how many people were in the chat during the conference. It was just amazing. So we'll be getting that stuff out. The big thing we want to do is make this available for everyone. So again, we have a team working on editing all like the hours and hours of stuff now. But instead of trying to make this something where you have to pay for later on and stuff like that, we won't be able to offer CE, but for everyone, this is going to be free. So we're gonna have it to where you go to the Empower RX conference site. Again, once this is all done, the slides, the recordings, everything that was there will be available for you guys. So definitely, I will let you know and email. And of course, one thing I do, I'm gonna tweet myself off, so you will know when it's available. So thank everyone who made Empower what it was. Again, it was special. You know, I dropped a little tear at the end there. I was like, this is amazing. So super excited for that. And of course, guys, I always mention that if you want to get part of some of the content that I'm doing outside of my premium website is PACU, Pharmacy and Acute Care University. If you're interested in contributing, if it's something that you want to see how I can get all this information right in front of me, our app just dropped this month, so you can definitely go check this out. Just go to Pharmacy/Acute Care University, and of course, just visit the show notes. All of it's going to be there. Marc, thank you again. The Charmist is in the house. Thank everyone for listening to another episode. And you guys know how I close it out. You don't have to be a pharmacist. You don't have to work in the ED, but everything you do, make sure you farm so hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't there.
Perfect.